our magic stated and the slides are up. We are pleased to be able to present to you today for the January in National Consortium of Telehealth Resource Centers conference. And on behalf of my colleagues, Mark Vanderworth and Carl Taylor, we look forward to be able to present this program to you today. So next slide, Arya. Just talk to you a little bit about the National Consortium of Telehealth Resource Centers. We are 14 telehealth resource centers across the United States. There are 12 regional and 2 national ones. TTAC, which is the National Technology Telehealth Resource Center, is your presenter for today's conference. Go ahead, Arya. So just a few tips and notes about today's webinar. Your phone and computer microphone are muted. If we do not reach your question, please contact your regional TRC. There may be delays in some response time, and this is our national website web link, and there's a lot of information on that website in addition to the regional TRC. So please take a chance to look around on it. You might find some real valuable information there. Please fill out the post-webinar survey. This webinar is being recorded and it will be posted to our YouTube channel, which is identified there below. So next slide, Arya. So at this point, Mark, I think that's our slide deck. And so I would like to introduce to you the 2 gentlemen who are going to be speaking to you today. We were just talking about the fact that we've known each other for about 20 years, so we must have met in grade school. Mark Vanderworth will be our first presenter, and Mark was really the lead on this project that we did. When the COVID crisis came around, the TRCs all got together and figured out what would be the best way for them to address this issue. And so for TTAC, the thing that we wanted to do is talk about how technology could be used in providing telehealth care during the COVID crisis. So our first presenter will be Mark Vanderworth. And like I said, I've known Mark for a long time, most of the time of which he has been a mentor to me and a number of other people in the telehealth field. Mark also has a wealth of experience from being the CEO of BannerHealth, Telehealth at BannerHealth. I just gave you a promotion, Mark.
Thank you.
To the Vice President of eHealth and Strategic Relationships at Nonin Medical, and he's a former CEO of AMD Global Telemedicine. And then Carl Taylor, like I said, I've known Carl forever as well, and Carl has served in many capacities working with me over the years. And one of the things that I really relied on him is his disaster preparedness knowledge and experience. Currently, Carl is a regional vice president for provider engagement at Humana, South Florida. So at this point, I will go ahead and turn it over to Mark to start our presentation. Mark.
Thank you, Doris. Let me bring up my slides. So thank you, everybody. And as Doris said, I mean, this is a very interesting project, and actually it's still a project in process. The idea here was to really look at the demands of delivering healthcare within a pandemic, and how could telemedicine and related technology help answer the really tight demands on the pressures that are put on healthcare providers. We kind of started with the classic approach. Rather than start with an answer, let's start with a problem and figure out how we can address it. So we identified the critical issues that were facing providers, and providers, we're talking about physicians and hospitals as those provider groups. define the issues and the specific needs. We try to dig into what is really being pressuring these providers and what's really the things that is really creating the greatest challenge with them. And then we sat down and identified solutions for each of those issues using telemedicine and related technologies. And by the way, for this project, we took a pretty liberal definition of telemedicine. So telemedicine, e-health, digital health are all included in this. And then the next step was to develop an action plan. This was not intended to be a report. This was not intended to be a study. This was intended to be a plan that you could grab off the shelf, and it would look at the major issues, present solutions to those issues, and then even go one step further to provide some of the technologies that you could also take off the shelf to implement those things. A big part of it was, of course, identifying the technologies, which I just touched on. We also created a complete policy regulatory summary and policy summary recommendations to policymakers so that, number one, you'll know the policy regulatory issues that you deal with, but also provide guidance to policymakers. The task force was made up of people from a broad range of folks and expertise levels, really leaders within each one of these segments. Carl and Doris were both part of the task force as well. We really wanted to attack it from every direction. That's really the only way to really understand an issue, number one. And number two, the viability of a solution. We've already published or are publishing a first draft. We were actually asked to move up our delivery date because COVID pandemic is reaching its second spike, and we thought that a lot of these things could be used now. We're right now finishing up phase 2, which is the final plan. That will be available fairly soon as well. And also for the TTAC is going to take some of the technologies that we've identified, and they're going to provide an assessment of some of those technologies and provide direct guidance on those technologies to the TRCs. The third phase is really a jump to a slightly different direction. That is to identify where telemedicine has been used and where it has been used successfully and unsuccessfully. This directly overlaps a project that's being that many of you are probably involved in, and Kathy Charba is leading. We're going to be going directly with you, supporting Kathy Charba. We're going to take a slightly different cut at it, but really, kind of giving it more texture and hopefully a better result. So let's talk about the critical issues first. What are the ones that we identified that we believed telemedicine could have a real impact on? And I'll not spend a lot of time on each one. And I'm going to, after we go through the list of 11 critical issues, I'm going to jump and just look at 2 of them, kind of give you an example of what this action plan looks like. So obviously these are forward. Keeping care protocols up to date, bubbled up as one of the number 1 issues. The understanding of COVID has rapidly progressed, and as most of you know, the treatment protocols, the pharmaceutical approaches, et cetera, have changed radically over the past 10 months. And keeping up to date with that has really saved lives. It's not easy. Data is coming from a bunch of different places. How do you keep it up to date? How do you make sure your providers are up to date on what the latest protocol and improvements to care are? And then, as rudimentally as this might sound, but keeping the hospital open. I'll talk about that a little bit more, so I'm going to skip it right now. Then focus on diverting potentially affected away from the hospital, not only to keep infection out of the hospital, but also to keep the uninfected from being infected at the hospital. Replacing and covering for staff, containment once COVID-19 is in your facility, providing access to urgent care, and more important, ongoing care follow-up, really maintaining the continuity of care. And here's the rest. 7 is really providing care at home. And this is one different, and I will go into this a little more deeply, so I won't spend a lot of time here, but it is a much wider issue during a pandemic with much more expanded issues. And then Of course, was support working people at home. There's a lot of it going on, and we certainly could have done a lot better in preparing for that. We pulled behavioral health as a specific area. I know it's a medical specialty, but it turned out no more you looked at it, it was a behavioral specialty and clinical need and personal need that goes across every single segment of the people that we talk about. We then talked about transportation. By the way, I encourage you to read that part. It's a really interesting part of the demands that were put on to providers, but also some of the solutions. And then last, public health. So let me give you a couple examples. The first one we're going to do is number 2, and then we're going to jump to number 7. So this might seem like a fundamental thing, and how can telemedicine really contribute to this fundamental piece of economics for a hospital? We really have to understand that most hospitals in the United States, their revenue dropped on average about 40%. You can kind of imagine in your own lives what a 40% cut in pay would be, or if you own a business, what a 40% cut in revenue would be. It's disastrous, especially while you're increasing costs. You're supporting your facilities, you've got pressure on staff, you've got all these other things to worry about, but just keeping the business open is critical, and addressing that is critical, not only during the pandemic, but whether or not you survive after the pandemic. So again, after each one of the issues, and the issue is much more defined within the plan. Obviously, we're shortening it for the purposes of slides. But here are some of the ideas and solutions that really were critical. Keeping infection risk to a minimum, and we go and dive into that in some detail. Divert potentially infected before they arrive at the hospital, and just as important, to divert the uninfected before they leave at the hospital, so you don't expose the hospital or the uninfected patient. Key, conduct standard and appropriate medical specialty appointments with telemedicine and bill for the encounters wherever possible. It is one very good way of maintaining your revenue stream. Allow and enable staff to work from home. We'll talk about that in a greater detail in a later section, but it fits in this section as well. Your people have got to remain working. They have to remain productive. You've got to run your business. This is an essential part. Obviously, part of that's maintaining connectivity. A thing that we recommend within this is the first step. And if you can do it in advance of a pandemic, but if you can't, the first step is really to find out right away whether or not people can work at home, and find out what the connectivity demands and shortcomings are. A big thing that we discussed in depth was getting rid of physical waiting rooms and create a virtual drive-up waiting rooms. If you really look into this, it not only is this essential in a pandemic, but you really think about the efficient running of your hospitals and the quality of service to your patient. This is probably something that we should be looking at whether or not we've got a pandemic. I'll keep going on example 2. Again, it kind of gives you an idea of how deep we go into this, but keep infected people out of the hospital, protect the providers, reduce the need to enter infected rooms. And an interesting thing, and a lot of you probably realize this, is just a pat and a pull technology in the patient's room to allow them not only to be less isolated from their loved ones and caregivers, but also allow the nurses and doctors to round into that room without even having to enter them physically. Obviously, considering robotics, pat and a pull we just talked about, it really, for the hospitals that implemented it properly, reduced the demand of PPEs substantially. Again, relieve the workload on key providers. You're going to find in your assessment that there are some providers that are really under severe demand. And one of them are the epidemiologists. Everybody needs them for clinical purposes. They're also trying to keep protocols up to date. They're also under demand from the press and from management and everyone else that wants to talk to them. There are ways that you can reduce the demands on those people with call management and other communication technologies. Constantly assess the condition of your staff, use surveys and other tools. You need to make sure that your staff is motivated, protected, especially under constant stress. And then really go out of your way to inform your patients, community of what you're doing. Let them know that you've created a more safer environment. Let them know that what things that you've put in place. Basically the thing is give them the confidence so that they don't avoid the use of clinical services. So that was just one example. There's 11 examples. I'm going to give you one more, and that's provide care in the home. Originally, this was to create the ability to not only care for the home, but also to be able to rotate patients out of the hospital, and perhaps sicker and sicker patients as you needed those rooms. This is a much more complex environment than we're used to. I mean, most of us are used to chronic disease management, remote patient management in the home. But this changes. Not only are we dealing with the classic hypertension, CHF, COPD, diabetes, et cetera, but now you're caring for patients with COVID in their home. It's a different animal. The second part of this is, if you will, expanding those services so that you are able to rotate patients out of the hospital. There's also an interesting twist. A lot of the data that came in told us that there has been a significant increase in death rates among CHF patients. And this pretty much tied back to disruption in their continuity of care, and gives you just one more reason to really take a more serious look at CHF patients and put them on home monitoring, especially during a pandemic when they're going to be hesitant and there's going to be barriers for them to have the right follow-up that they should have. And again, we dive into ideas and solutions. I won't dive into any of them in detail. That's what the plan's for. But here are some of the ideas and solutions to these things. Automate post-procedure reminders, instructions, classic digital front door work for a hospital. Same thing, making sure that the transition from the hospital to home care is extremely well done. Really making sure that we don't allow gaps to occur within the continuum of care. We certainly support, especially in COVID, but outside of COVID, implementation of RPM and chronic disease management. Make sure that you're putting the measurements for success, the coding, and the billing in place. Again, you've got to somehow make up for some of the billing that's not happening, and we also want to make sure that we understand that we're doing a good job and be able to measure it for success. Using other systems to prevent gaps in the care. Not really going beyond the traditional RPM, CDM models to really be making sure that you have a constant, regular communication with that patient. In COVID, social requirements become much more substantial. They are going to be isolated. Let's make sure that as we put these programs in place, we take care of isolation, not only from us as providers, but also from the people that surround them and provide their care and social support. Provide remote communication for family and friends outside the home. Again, it's kind of a link to the same thing, but let's make sure we take that in consideration when we're deciding what RPM to put in place. And then engage hospital owners in your area, really to be as partners. Let's work together with home care agencies and so on, so they understand what you're doing and what you can accomplish, but also make sure that they're maintaining the communication with the patient as well. A critical area here is, you all have come across the fact that people sometimes are reticent to send patients home for a variety of reasons. So this is a very good opportunity to make sure you're training your providers on the capabilities of these services, to make sure that, number one, they're informed, and number two, that they're confident in decisions and they're making the right decisions to send a patient home. So for every single one of the ideas and solutions we provide, we also provided examples of technology that's available today. They're classified pretty much exactly by the ideas. You can link them closely together, but if you're going to want to do a remote screening to keep COVID patients away from the hospital, here's some technologies that are available today, and so on. In addition to giving 5 or more examples for each one, we also provided examples and references of them actually being used. So how was this type of technology implemented? What happened when it was implemented? And what are the things that we learned? But rather than just give you a technology and say goodbye, we wanted to make sure that you got those technologies within the context of how they're used, when they're used, and what happens. Now, in the second phase, which is when we're now, we'll be identifying more of these. And in phase 3, that's when TTAC will actually take examples of this technology, assess the technology, and provide more specific guidance. As I said, we did a complete telehealth policy and regulatory. We covered all the issues on the slide here, which are all the typical ones you'd expect. We came to a number of conclusions. And one of the conclusions that we're making is that parity in payment for telemedicine should be continued for the next 2 to 3 years. And the reasoning is that until now, we've never really done high volume telemedicine in the United States. We've seen growth this year of 12,000% in claims, but to CMS, and about 1,000% in the number of homes, the number of systems that are being implemented. We can finally really have a good piece of data to make the kinds of decisions around what do these things really cost, what benefit do they really provide, and what is their value, and make the reimbursement based on those things rather than just kind of the loose information that we have today. Again, this is not for the shelf. We don't want this to go on your shelf. It's not a study. It's not a report. It's a pick it up and use it plan that you can apply. We recommend applying it to your day-to-day operations, but most critical, especially as we look forward to our hospital systems, here's a really good opportunity for people in the telemedicine world to integrate this into your strategic and disaster recovery plans. It's essential and gives you one more reason why telemedicine should be implemented and implemented now. So these are us. You can contact me directly, obviously. You can contact Doris or Jordan Bird, who most of you know, through TTAC. This plan will be available through TTAC. If you can either go to TTAC and find on the website when this will be available. And if you want to make sure that you're on the list, go ahead and mail any of these 3 people. And thank you. I turn it over to you, Carl.
All right, great. Mark, can you hear me?
I can hear you clear.
All right, perfect. Thank you very much. A great presentation. And for those of you who have taken time out of your busy day to dial in and join us, thank you very much. I'm going to start off with perhaps a bit of disappointment for some of you. I don't use slides. So this is really going to be more of a dialogue and a chat. So if you're looking for slides, grab Mark's because they're very comprehensive and a great place forward. I'm going to touch on 3 things, and let me start right out of the gate. Mark talks about that these plans that we've been working on are really meant to be given to you. It's really a beginning point. The process of planning really is invaluable, and it really is how you take the work that we've done and really apply it to your everyday life and your everyday work. I tend to believe that what happens is when plans get better, it's because we build communities of users and communities of people that have experience around the plans. And I'll give you a couple of quick examples. Mark used the idea of the iPad on an IV pole. That was actually a project that Doris and I did together a few years ago. We're both younger then, but not that long ago, in which we took an iPad on an IV pole and we took it out to rural and frontier hospitals, plural, throughout northwestern Montana and dropped these off. It was very important from our experience that the technology had to be easy to use. The bandwidth had to be very bandwidth friendly, and it had to be portable to go from exam bed to exam room and then on occasion back to a provider's office to have a discussion. And so the IV pole became a very low cost solution to be able to transport it. And so Doris and I both have a lot of experience in deploying iPads on IV poles. And so when this plan came up, we both sort of put our hand up and said, we have a solution that we know works. But it's not just the deployment of the iPad on the IV pole. The real lessons learned that really came about, well, yeah, but how does that information coming out of that iPad find its way back to the hospital in Billings, Montana, in a way that integrates with its EMR, in a way that integrates into the ER, and in a way that creates that patient visit as if it's any other patient visit. One of the lessons we've all learned around the success of telemedicine is it has to fit to the extent possible into the workflow of the other providers that are either generating or receiving the consults. And so literally what we did was we created an exam room in the hospital. We created the same triage system. So as a call came in on the iPad, a nurse would triage that patient about how quickly they needed to be seen. And then the doctor, going from exam room to exam room, would simply hit the telehealth exam room and see the patient. And so those are lessons learned that got embedded into this plan. But I know that you've got other lessons because you've been in this business for a long time. And so as you get this plan, make it yours, improve it, and share those lessons learned back with the greater community. Same thing Mark talked about with the infectious disease group. Again, that was a network that Doris and I built a number of years ago in Montana. And it was interesting because Montana's a huge state. The infectious disease docs were scattered all over the state. And even though they were seeing patients with common conditions, they were treating them through uncommon means. And the doctors actually loved it because it brought them closer together and it gave them support and recommendations of what they should be doing. And so take this plan, make it yours, and improve upon it. Mark talked about, for example, that one of the two subjects he covered was about telehealth going to the home. And so when I think about ways to look at plans, one of the foundations of these plans, of course, is clinical. Telehealth is a clinical experience for many of the things that we do. And so we've seen an explosion of companies leveraging telehealth going to the home. I started one of the early remote patient monitoring programs in this country. It's now still going 20 years later. And it was, for us, it was very simple. It was, could the patient get a 1-800 number, dial in and give us a digital readout on their spirometer, their glucometer, or their, or their scales. It was very easy with blood pressure cuff, very easy, low cost technology, lots of lessons learned, remote patient monitoring, and we had significant effect, improvements on members who then suddenly became more compliant with drug, diet, and exercise. And oh, by the way, quit going to the emergency room. But today, as I look at what's being deployed, literally what's being sent to the home are telemetry units, very sophisticated equipment, supported by very, 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 astute subspecialty physicians, everything from neonatologists to cardiologists. And so the equipment deployed to the home has gotten far more sophisticated. And so lessons will be very important, I think, for all of us to say, if we're going to keep patients at home, what does that look like? Can we, in fact, establish a sniff unit in home using telemetry? We can, but your experiences will help inform the plans about how best to go about that, both from a technology perspective, a clinician perspective, a workflow perspective, and obviously, ultimately, a reimbursement and value perspective, because that's part of what we do. Can you deploy a COVID management scenario in a home-based setting? You can. It's being done. But what works and what does it look like? What does it feel like? Can we move forward with a movement that started a few years ago called community paramedicine, where paramedics would take ambulances and go to the home, but connected back through telemedicine back to emergency room doctors to be able to get orders, to be able to treat patients with significant reductions in the need for transport. And so those are the sort of lessons learned that I think that we're all going to experience. We certainly see those. I know you do. So take the plan, patient at home, think about what's being deployed, how's it being deployed, who's deploying it, how's it successful. And there's an explosion of companies that are coming out right now. And so each of you will have experiences with the clinical side. The second foundational piece, I think, to this is really around what I would call administrative, regulatory, and billing sort of subset. And that is, well, what are the ground rules? So if we're going to set up a SNF at home or a cardiac unit or a COVID hospital at home or an urgent care setting or a remote NICU, one of the things, and Mark and I have talked a lot about this, is in the early days of COVID, it seemed like that CMS and the states were literally writing new telemedicine regulations every day. I used the phrase the last time Mark and I did this, that if you were posting telemedicine regulations to your website, it may or may not have been good at the time you posted it. It most certainly wouldn't have been up to date by the next day. And so one of the things that's going to be very important is we look at this plan, as you help us define, well, here's what's working, here's the technology, here's the how to do it, here's what makes an iPad on an IV pole work, is what about the regulatory constraints or regulatory requirements? What are the administrative capabilities? How does what's going on in the home with these standalone units find its way back to the primary care physician, or find its way back into the other specialist? How does it find its way back to the payer that's paying for it? How does it find its way back into the traditional care side, so that we know what's going on and what's being done for the patient in that setting? And so that's what I will call the administrative side. And again, that's going to be federal regulations, it's going to be state regulations, and it most certainly is going to be payer policy or payer procedures, which then gets me to my third piece, and that is, well, what are we getting paid for that? So we're going to deploy a telemetry unit at the home. It's a great way for, if you think about hospitals are trying to discharge patients, but SNFs in many cases are full. SNFs, LTACs, and IRFs are often full right now because of the number of patients. So we want to discharge the patient back to the home. What's the reimbursement model for that? We know what we get paid if the patient's in a hospital. We know if they're in a SNF, an LTAC, or an IRF, we know what that rate is. But now we're going to send a patient home with technology. What does that look like? And so again, I think part of the expertise of all of you is really to take these plans and continue to build on them. Clinical, administrative, regulatory, and billing. And then the third thing that I would say is to go one step beyond the plans that we've done. I think Mark put up, was it 11, I think, things that we've taken on. I can tell you there's a 12th one that we ought to be working on right now, and that's vaccines. I think we need to add to this work to talk about the role of telehealth and vaccines. I don't know the experience in each of your markets. The vaccine rollout to me appears choppy, a bit uneven. Vaccines are available, then they're not available. Websites are set up and then they crash and get appointments with them. I think there was a subset of people, and I probably was among them, so I should confess, that kind of thought the demand early on might be a little tepid, that people would want to watch and see how people were navigating this and see whether or not there were adverse events. That's experience, certainly not in Florida. I don't know about your experience. In fact, it's been exactly the opposite. It seems like literally, and this is true certainly with seniors, that every senior wants to be first in line to get the vaccine. And so why the websites have crashed. And so the question is, how can telehealth play a role? Can we help with the demand management? Can we help with clinical supervision? Can we help in managing, tracking whether or not there are adverse events or not? Can we help in prioritizing the members and how they get their care and where they get their care? Can we help with some of the clinical staffing? I think that's still aspirational for telehealth, perhaps not in other markets, but at least in mine. I think the role of telehealth on the vaccine side is still a bit aspirational, but it's certainly something that I'm watching going, I think there's room for help and improvement. And I think, frankly, I think that's something we all want. So bucket number one of my sort of three titles are: take the plans and the great work that Mark and Doris have led and embrace them, make them yours, but more importantly, improve upon them. And as you improve upon them, share those improvements back through your TRCs and share those, so that the next time Mark does this presentation, there's another slide or two that says, oh, by the way, here's what's working in California, or here's what's working in Montana, or here's what's working in Texas. I think that's where this community that's on this call today gets really, really, really good. The second thing that I think we haven't quite yet dug fully into yet, but you will as you launch these plans, is really what I call the last mile challenges. And I think we've all, because we've been in this business for a long time, I tend to bucket last mile challenges into two buckets. The first is the digital piece, which is, does the home have the bandwidth to support all of this telemetry equipment that's going in it? Does the,
speaking of bandwidth, now Carl did, in all fairness to Carl, he did, he does have his audio.
Doris,
There you are.
Doris,
Okay.
back? Yeah,
Back.
sorry about that. Yeah, our filter doesn't like Zoom sometimes. So what I'm saying is, from the home, don't presume that seniors have the right technology. Don't presume they've got an iPad at home. They don't. Don't presume that they've got a smartphone. They don't. And so if we're going to deploy to the home, the very first question we ask is the home digitally ready to be able to embrace it? Question mark. And then there's the analog piece to it. And the analog piece is, well, is the senior, for example, are they capable? Are they functional? Would the clinical experience be better off if we did it when maybe their daughter was over, or their home health nurse was there, or their social worker was there? Should we schedule some of these home visits in a way that leverages perhaps some of the existing clinical resources that are already engaging the member in the home in order to have a more fulsome review of that patient's conditions? You solve those or resolve those, I think would be great. In rural Alabama, which is where I worked when we started remote patient monitoring, that's why we defaulted to a telephone, because equipment really had challenges. Internet was certainly not a given. Smartphones were a given. And if not your phone, borrow somebody else's, dial a 1-800 number with your own ID. And so at least we knew it was you. And so that's how we did the workaround. So last mile matters. The third piece, and this is particularly true for this audience and for this group, is the need for training. Gosh, right after 9/11, I had a chance to set up something called the Advanced Regional Response Training Center. And to date, the training center is still up and running. We've trained about 15,000 healthcare professionals in how to respond to disasters. This year, I've probably gotten more thank you notes than probably ever before as we've gone through this pandemic and COVID planning side. There's such a need for additional training. Think about this for a second. And Mark used a statistic of the huge, 12,000% increase in billings going to CMS. We literally, I mean, for Mark and Doris and I, having been in this business for 20 plus years, like last week we used 30 years. So we're getting younger. I like this. Maybe by next week, it'll be 10 years we've been in the business. But in any event, we went from a fledgling industry that kind of began to crawl and then began to walk. And then all of a sudden with COVID just went full bore, right? And went from a walk to 100 miles an hour. And yet a lot of doctors who picked up telemedicine, and I use that in the largest of quotes, had no idea what it was, didn't know how to use it, didn't know what they should be doing. I had to laugh. One of the doctors complaining that I heard last week saying, well, I can't believe CMS doesn't like what I've been doing. Well, what have you been doing? Well, I've been calling the patients. No, CMS defines, telemedicine as interactive voice and video. Oh, well, nobody told me that. And so one of the things, I think there's this huge training opportunity out there to make sure that the physicians are familiar with the emerging technology, to make sure physicians are aware of the needs both in a hospital, out of a hospital, and in the home. What are the things that they need to be successful? I think Mark believes, and I know Doris believes, and I believe that telemedicine will now be ingrained as a part of the care delivery system going forward. I think that patients now realizing that they can see their physician over Zoom or over secure video chat of some kind, don't really want to go wait in a waiting room for 45 minutes or an hour to see their doctor anymore. And so I think what we've got to do is now say, what can we do to help? How do we train? And even around training around how do we use telemedicine for COVID as it stays a part of our community? And then how do we prepare and do better for the next event, whatever that next event is? How do we prepare and do better? I think we found, and I think Mark said it early on, right? The two key principles in disaster preparedness. One is situational awareness. What's going on around you? What's going on in your community? What's happening? Are the hospitals open or closed? Do they have beds or don't they have beds? Are my patients staying home? Are they going to the emergency room? Are they being admitted? What's happening with my patients? But then the second piece to that is the surge capacity management. And that's what Mark talked about before, which is surge capacity. Its best definition is having to do more for more with less. And so one of the challenges that we've got right now is we've got more patients going to the hospital as COVID becomes, again, we think we're in wave 3 now, an ever increasing presence in our community. And yet one of the things that's happening that we're certainly seeing, I think, across the country is the hospitals are beginning to lose some of their clinical staff. They're beginning to lose not just nurses, but they're also beginning to lose physicians, as other systems are paying bonuses as they're trying to leverage not just in the U.S. but outside the U.S. And so we're watching a really interesting dynamic that it's not just about managing. That it's not just about managing more patients coming in, but it's also having to manage your workforce and making sure that they're trained, they're ready, they're capable. And when that workforce is challenged, right? Surge capacity is really not just about numbers of patients, but it's about the resources that are available to be able to meet the needs of those patients as they come in. And if you don't have the resources, then the question, what do we do next? And how do we either transfer those patients? How do we send those patients back home? How do we manage surge? And that's really a lot of what we've been working on with these plans. And I think there's such a training opportunity, and I can think of no better group than the TRCs, because that is part of your mission. It's been part of your mission for a long time, is how do we reach out to the clinicians in our community and maybe use this plan as a beginning. We used to do kind of, when we started the regional training center, we started with kind of 2 courses. We expanded about 11 or 12, but we started with 2. One is, what am I afraid of? And 2, how do I plan for it? And so I taught the what are we afraid of, and Dave Wallace, who Doris knows, taught the and how do you plan for it? And those were the 2 courses that we taught for a long time. And so I really think this plan gives you that opportunity to say, what are we concerned about? We're certainly living that experience, but now there's, it's that experience and whatever comes next. And then how do we plan for it? And how do we take the lessons that we're learning, even do better? And the best time to do that, I will tell you in my experience, and I've been in the disaster space for a long time, the best time to plan to do better today, but also to be prepared and to do better for tomorrow, is now. It's when the experiences are fresh. It's when you've watched the change in the way that we've treated clinical care for COVID patients. It's when we're experiencing the supply chain disruptions. It's when we're watching the challenges of retaining our clinical staff. It's when we're trying to figure out how to keep the site up to be able to register people for vaccines. The best time to learn those lessons, to work through those lessons, to build them into your plan, and then to share them with others, is right now, today, when you're going through those. So I'm going to leave my comments with that, except to say thank you very much for having us. I love the project that Mark and Doris have been working on. I've been so grateful that they invited me to be an incredibly tiny part of it. I think our work and our success will really be realized with how you take what we've done and simply make it better. Thank you very much.
Thank you, Carl and Mark. And now we'll open it up for any questions that members of the audience may have. Right now, we don't have any questions in the queue. While we're waiting, I do have one question, and this would probably, either one of you actually could answer. One of the things Jordan and I have been working on is how do we train the provider to really deal with the patient in their home environment, right? We like you said, Carl, where you don't have good bandwidth, people have never been on video before. You've got a doctor trying to do a clinical exam, when in the past, that patient went into a clinic and then the clinic staff ran the technology and everything was good and everything worked. And we had to do that in order for people to adapt, especially providers, to adapt to telehealth. Now, they're adapting to telehealth because they want to see their patient, but they've got a patient who knows nothing about being on a video call.
No, I think, Doris, you're 100%. Use a phrase called clinical equivalency. And if you think about, hold on a second, I just need to get this out of my way. Hold on, sorry about that. I use a phrase called clinical equivalency. And so if you think about a visit to your doctor's office, in many cases, what she's doing or he's doing is they're relying on images, they're relying on labs, maybe they're relying on pathology, they're certainly relying on physiologic data, right? Weight, blood pressure, peak flow, blood sugar, all those things. And so some, and in many cases, maybe all of those are not present now. So when your primary care physician calls and says, hey, Doris, how are you doing? The question is whether or not that how are you doing is a clinical equivalent to you if you were in that provider's office, as you've said, well, yeah, but you've done a blood draw. You've taken my weight, you've listened to my chest, you've looked at my EKG, you've done all these other things in order to have a robust clinical discussion with me. And so then the question becomes, well, then what's needed? And I think there's a really great opportunity to have a discussion with the providers that are using telemedicine to say, how confident are you that the telehealth consult is a clinical equivalent? And if it's not, how can we make it better, right? Could we deploy a nurse with technology to the home? Could we do labs and blood draw in advance, then have it in front so that when you're doing the exam, you've got the data? Can we deploy more remote patient monitoring equipment, scales, blood, spirometry, glucose? Can we deploy that equipment so that then when you're talking to the patient and say, well, what's your weight? Well, here it is, I just weighed. What's your blood pressure? Well, I just took my blood pressure. Can we use a combination of remote patient monitoring with video conferencing with a visit and see if we can close that loop? When I talk to my doctor, it's like you and I talking right now, right? I mean, and maybe that's enough. Maybe that's all he needs to do is to see me and talk to me and ask me a series of questions. I normally get a pre-visit survey before. So I check boxes of how you doing and what are you doing. That survey's on his EMR. So he has asked me questions before the visit and I do respond to those and send them back. But is that enough? I don't know that answer. And I think that's a great question to ask clinicians. And if they're comfortable, then life's good. If they're not comfortable, the question is, how can we close that loop, right, to make that visit a more clinically equivalent visit?
Right, you're absolutely right, because we don't want providers to say, oh, this didn't work, right? During the pandemic, it didn't work, so I'm not going to do it anymore. We do have a question. How can telehealth clinics help in the current vaccination process as the most needed the communities on a national scale?
Well, there was just an op-ed in the Miami Herald in which the writer, which I thought struck a chord, said, you've already got a vaccine distribution system. It's called primary care offices. Why don't we just use the primary care offices as opposed to creating these other centers? I would encourage the primary care clinics to reach out to your health departments and say, why don't you let us help? I will urge caution, right? So let me spend a minute on caution. If you know the Pfizer vaccine, as you know, that requires a significant refrigeration capability. We actually have had one of our providers that has ordered it. It's on back order, as you can imagine. But the Pfizer vaccine comes with logistics issues. And so you've got to make sure you're prepared. The Moderna vaccine does not have those same ultra cold requirements. And so you can store it more on the refrigeration side. So make sure you're able to either do one of two things. If you're doing Pfizer, you have the ability to have really strong throughput to do lots of vaccinations. Moderna, you've got a bit more time, and so you can have a bit more of a measured pace. And so I would encourage you to call your health department. The other thing, though, that I would also encourage you to do is to do a few first. Because one of the things that you may find is the vaccination itself is the vaccination. Depends on your demand, whether or not your website crashes or things happen, but vaccination is vaccination. But when I had my Pfizer round one, it's the only benefit to being old is you get in line first. And so when I had my Pfizer round one, the consent form and information form that I had to fill out was 12 pages long, filled out in pen by me on top of a garbage can while waiting in line as we were moving through with 600 of my closest friends to get my vaccine. I don't know where that information goes. I don't know who enters it, but it's important. It really is important because we need to track, one, who's been vaccinated, and two, how do we do? And does it work? I mean, this is very early in this experience. And so there's one thing that I was asked that wasn't critically important. But as I walked out and I threw my 12-page thing in this big bucket of lots of other papers with everybody else, I thought, oh my gosh, who has to enter all this stuff? And then my second thought was, who in the world is going to read my handwriting, which Doris is nearly unintelligible. But I thought, who's going to enter all this? And so I, yes, please be part of the solution. Absolutely. Work with your health department because they're probably the ones closest to getting a vaccine supply. Test your throughput capacity, but also test the administrative needs to make sure that you can manage these forms and keep up with those, because I think that's a unique burden, perhaps that I certainly hadn't thought of until I went through it.
There's another piece to that. I was just talking to a CIO of a hospital 2 days ago about the fact that one of the challenges of vaccine, of course, is setting up the appointment, making sure it's scheduled, make sure the schedule is set up properly, reminded properly, etc. There also is some overlaps from other things we're doing. We talked about is some of the things that we talked about in the telemedicine thing directly support the application of vaccines. Again, the same scheduling systems that you use for on-demand telemedicine, the same registration that allows you to fill that form that Carl was talking about online before you ever even get there in digitally versus penmanship. The same technologies that you use to eliminate the waiting room to basically do live scheduling and live flow of the patient as they arrive. Those same technologies can be used for vaccine. Same demand, same thing. So when you're looking about implementing some of these basic parts of telemedicine, realize that it's not just scheduling your telemedicine call, it could also be scheduling your vaccine. It's not just registration for you, it could also be doing all the registration and documentation for that application, etc. So there's a lot of multi-uses of these technology, and frankly, when you're talking to a CIO, it's good to know that you have more than one use for his expense. It's not a bad thing to talk about. So anyway, look at how the basic fundamental pieces of telemedicine scheduling and implementation work extremely well for vaccine distribution.
Thank you, guys. We have time for maybe one more question. I don't see any more questions in the queue right now. So,
come on, someone out there, hit us with something. We're
hit us, man. There's one that just came in. So telemedicine documentation services requirements are still in place, such as physical examination of the affected body part system. Is that still required?
For,
do you have to see the patient before you can do a telemedicine encounter? Is I think what they're asking. Oh.
Well, it depends on the environment a little bit. Go ahead, Doris. Sorry.
The physician thinks that they don't need to report PE, physical examination.
Well, there's about three questions there. One question, on-demand telemedicine. You do not have to have an established relationship with the patient. It is a little bit more limiting, but on-demand telemedicine, just like you would see from a lot of the major vendors today, TTAC, American Well, SOC, et cetera, there is no requirement for a previous appointment. Now, there is some requirements around in some environments when you're prescribing certain kinds of drugs where a pre-requirement is required. I don't really think, kind of in Carl's comment about clinical equivalency, this is just another meeting with your doctor. What they required to do a physical meeting with you is required for this remote as well. So if you're talking about a body part that really needs to have a viewing, if you will, yes. You can't just go, well, I've got this. You still have to have an exam for the doctor to understand what's going on. Some of that can be done over video, some can't. You've got to figure out what the application is and what it can be.
Yeah, thanks, Mark. And I think, a lot of what telemedicine has done in the COVID crisis time period really is taken that chronic care management to a new level. So these are patients you already know, you've been working with them, you already know they have diabetes, you know what their history is, you can do some of the remote monitoring like what Carl was talking about. That's certainly where we've seen that telemedicine has really been able to step up and play a role with these patients that generally would come into the clinic 3 or 4 times a year before, and they're not coming in now. So how are we able to manage this patient better in the home environment? We are at 4 minutes to the hour, and I know that Arya has a few more slides left that he needs to go over. So we want to thank all of you for listening to our presentation today. As Arya said, those slides will be available within the next couple of days on the YouTube, and this has been recorded. So you'll be able to look at the PowerPoint presentation and the video. So today was a part of the NCTRC webinar series that occurs every third Thursday of the month. The next one will be on telehealth policy update. What has happened and what are we looking for in 2021? That will be presented by our own policy TRC executive, Mei Kwong. And that the date of that will be February 18th from 11 a.m. to 12 p.m. Pacific time. And we do ask you to please fill out our survey. This helps us to choose topics for future presentations. And so we really appreciate you taking just a few minutes to let us know how we did today. And with that, I would like to thank all of you for attending today. And we look forward to the next opportunity we get to see you on video.
Thank you very much, Doris. Thanks, Mark. Take care, guys.
Yep. Thanks. Thanks the same. And thanks for everybody listening in. I really appreciate it.
Great fun.